Good morning. Today's topic is prognosis. Moving on to the contents. Contents are introduction, types of prognosis, factors in determination of prognosis, prognosis for patients with periodontitis, re-evaluation of prognosis after placement therapy, and conclusion. Next, moving on to the prognosis definition. Prognosis, it is the prediction of probable cause, duration, and outcome of a disease based on a general knowledge of the pathogenesis of the disease and presence of risk factors for the disease. So it is the prediction of probable cause, duration, and outcome of disease, which is based on the general knowledge of its pathogenesis and the presence of risk factors. Next, moving on to the classification. It is a classification by Medgar in 1991. Based on this, it is categorized as good, fair, poor, questionable, and hopeless. So, moving on to the first one, which is good. That is, the prognosis is good, which is the definition. It is the control of etiologic factors and adequate periodontal support ensure the tooth will be easy to maintain by the patient and the clinician. So with the control of the etiologic factors and proper adequate periodontal treatment and maintenance, the prognosis can be good. Moving on to the next one, fair. In this case, approximately there is 25% of attachment loss and or a class 1 furcation involvement. Next is poor. That is the attachment loss is 50% and class 2 furcation involvement. Questionable, that is greater than 50% of attachment loss, poor crown to root ratio, poor root form, class 2 furcations or class 3 furcation involvements. And in case of mobility, that is greater than grade 2 mobility and there is root proximity. Moving on to the next one, that is hopeless. Hopeless is, in this case, there is inadequate attachment to maintain health, comfort, and function. So, according to Medgar's classification in 1991, this is categorized as good, fair, poor, questionable, and hopeless. Next is the overall versus individual tooth prognosis. So overall tooth prognosis means which is concerned with the whole dentition. That is overall means whole dentition. And in case of individual tooth prognosis, which is determined after the overall prognosis. There are certain factors which determine the prognosis. So these are factors which determine the prognosis are, first one is the clinical, overall clinical factors, systemic and environmental factors, local factors, anatomic factors, prosthetic and restorative factors. First one is overall clinical factors. In that, there's patient age. The factors are patient age, disease severity, biofilm control, patient complaints. These all comes under overall clinical factors. Next is the systemic and environmental factors. In systemic and environmental factors, there's smoking, systemic disease or conditions like diabetes mellitus, example diabetes mellitus, and genetic factors and stress. So next is the local factors. In local factors, biofilm and calculus, subgingival restoration. These all comes under local factors. There's factors like biofilm, plaque calculus, subgingival restorations, etc. Next, moving on to the anatomic factors. Anatomic factors are short tapered roots, cervical enamel projections, enamel pearls, bifurcation bridges, root concavities, developmental grooves, root proximity, furcation invasion, and tooth mobility. Next is the prosthetic and restorative factors. These are caries, tooth vitality, root resorption, abutment selection. So these are the factors which determine the prognosis. Based on this factor, we can determine what type of prognosis is. So moving on to the overall clinical factors. First one is age. When two patients with one patient is younger age and older age, in that patient with comparable levels of remaining connective tissue attachment. So two patients of younger age and older age with comparable levels of remaining connective tissue attachment and alveolar bone, prognosis is better for older one. That the reason is in younger patients, there is shorter time frame in the periodontal destruction has occurred. So that is the reason why the older patients will have good prognosis. And also in younger patients, there might be aggressive type of periodontitis or systemic disease or smoking that causes the disease. So in this case, we can see that older patients will have good prognosis compared to the younger patients. Next is disease severity. Following variables should be carefully recorded. In disease, these are the factors which determine the severity of the disease. That is pocket depth, level of attachment, degree of bone loss, and type of bone defect. Next is type of bone defect. See the figure. In this figure, prognosis of tooth A is better than there's two teeth images of two teeth. One is A and B. In this picture, the A has better prognosis than that of B, despite less bone on one side of the surface of A. The reason is the center of rotation of A is closer to the crown. The distribution of occlusal forces to the periodontium is more favorable than that of B. Next is the plaque control. Plaque control. In plaque is the main etiology factor which leads to gingivitis and periodontitis. So, when the patient is able to effectively remove plaque on daily basis, then there will be good prognosis. Next is the patient complaints and cooperation. This depends upon the patient's attitude, desire to retain the natural teeth, ability to maintain good oral hygiene. These are the factors which determine the patient complaints. Next is the systemic and environmental factors. First one is smoking. In a smoker with slight to moderate periodontitis, the prognosis can be fair to poor. But in smoker with severe periodontitis, the prognosis is poor to hopeless. So if the patient is able to stop smoking or smoke after smoking cessation, the prognosis will change. So they upgrade the prognosis. Next is a systemic disease or condition. Patients with well-controlled diabetes and slight to moderate periodontitis who comply with their recommended periodontal treatment, it is favorable prognosis. So in case of systemic disease, if the patient is having a, in case of example, in case of diabetes, if the patient is having a well-controlled diabetes status and there is slight to moderate periodontitis in that patient and which comply with the recommended and they comply with the recommended periodontal treatment, then the prognosis can be favorable prognosis. Moving on to genetic factors. Genetic polymorphism in interleukin-1 genes, it is associated with chronic periodontitis. Genetic factors influence serum immunoglobulin G2, antibody titers, and expression of Fc gamma receptors on neutrophils is significant in aggressive periodontitis. So this shows that there is a genetic relationship with periodontitis. So in this case, this factors is clear. So that is in case of chronic periodontitis or aggressive periodontitis, there is genetic relationship. And moving on to stress. Stress, it is a physical and emotional stress which alter the patient's ability to respond to periodontal treatment. So in case of stress also, the prognosis varies. Moving on to the local factors. First one is plaque and calculus. Good prognosis depends upon the ability of the patient and clinician to remove this etiologic factors. Main etiologic factor is plaque. So it is the prognosis depends upon the ability of the patient and the clinician, how they remove the etiologic factor. That means how they remove the plaque and calculus. It depends upon that the prognosis can be determined. Moving on to the subgingival restorations. Tooth with discrepancy in its subgingival margins has worse prognosis than a tooth with well-contoured supragingival margins. Anatomic factors: short tapered roots, large crown, cervical enamel projections, root concavities, palatogingival groove, access to furcation area. These all are the anatomical factors which creates plaque retentive area that can be difficult to clean. So plaque gets retained in these areas and which will become difficult to remove. So that will lead to poor prognosis. Next is the tooth mobility. Depending on the cause, mobility may be correctable. Eliminating the cause can stabilize the tooth and improve its prognosis. So when the etiology, when the mobility is corrected and eliminating its cause, which causes the mobility, which after stabilizing a tooth, its prognosis can be improved. Prosthetic and restorative factors. Prosthetic and restorative factors. First one is caries, tooth vitality, and root resorption. Teeth with extensive caries There will be adequate restoration, and endodontic therapy should be considered before undertaking a periodontal treatment. So before undertaking a periodontal treatment, when the tooth is having a very extensive caries, uh, endodontic therapy should be considered prior to the periodontal treatment. Periodontal prognosis of treated non-vital tooth does not differ from that of a vital tooth. That is, no attachment can occur both to the cementum of both non-vital tooth and vital tooth. Next is the abutment. Teeth that serve as abutment are subjected to increased functional demands. So there should be special oral hygiene measures that must be instituted in these areas. So when when one tooth is acting as an abutment, there will be more increased functional demands. There will be more of occlusal forces, and there will be more functional demands. So in that cases, we should consider special oral hygiene measures that should be instituted in these areas. So with that, we can improve the prognosis. So moving on to the prognosis of patients with gingival diseases. Gingivitis associated dental plaque only. Local irritants when in case of gingivitis, which is associated with dental plaque only, when local irritants are removed and along with that of patient complaints, we can convert to good prognosis. So when there is only plaque associated gingivitis, prognosis is good. When the patient is able to remove the local irritants and the patient compliance is good, then the prognosis is also good. Next is modifications. Plaque-induced gingival disease, which is modified by systemic factors. Plaque-induced gingival disease modified by medications. Gingival disease, which is modified by malnutrition. So these are the gingivitis, which is caused by other factors like systemic factors, medications, and malnutrition. In such cases, we should consider this reasons. That is the etiology. Non-plaque induced gingivitis, that is elimination of etiology factors. These cases, we should eliminate the reason or etiology which causes the gingivitis. Next is the prognosis for patients with periodontitis. Chronic periodontitis, removal of local plaque and retentive factors and severity, which improves the prognosis. In case of aggressive periodontitis, there should be early diagnosis and contributing factors and conservative treatment. So we should early diagnose the disease and factors which causes the disease, and also there should be conservative treatment provided. So in that case, we can improve the prognosis. In case of necrotizing periodontal disease, there should be control of primary and secondary etiologic factors. We should consider both primary and secondary etiologic factors. So next is the reevaluation of prognosis after phase 1 therapy. So after phase 1 therapy, after we do the phase 1 therapy, we should reevaluate the prognosis. The prognosis is actually determined after the diagnosis and before the treatment. So after the treatment also, we should reevaluate. After the phase 1 therapy, we should reevaluate the profile. We should reevaluate the prognosis. So in case after during the revaluation, if the pocket depth is less and inflammation after therapy, pocket depth and inflammation reduces after therapy, then the prognosis is better prognosis. If after the phase 1 therapy during the revaluation, the pocket depth is not reduced, then the prognosis move to poor overall prognosis. So after every phase 1 therapy, we should reevaluate the prognosis. So based on that, we can say either it is better prognosis or poor prognosis. Next is moving on to the conclusion. So the planning, the customized treatment for each patient does help in providing overall care to the patient.